Fungal keratitis. We have Dr. Namrata from RP Center speaking for intrastromal voriconazole in severe non-perforated fungal keratitis. Dr. Namrata, please.
So Prashant said that he couldn't really face up to me, so he couldn't come. So, so my debate is already over. And for this case, what would the House do? Very frankly. What would you do, Murli, since you have to, you would obviously do a therapeutic PK, but it's really not required. It's not coming, the image. Okay, so these are the cases that we published, and for this was in fact the first case for which we did intrastromal injections, and this is how it responded. So we didn't have to do a therapeutic PK at all for this. Now, intrastromal voriconazole gives you, or intrastromal injections give you window of opportunity to avoid PKP. They give you a more targeted drug delivery form of a system, and the antifungal therapy reduces the recurrence rate. And of course, therapeutic keratoplasty can be done in cases of perforations. If you see, the anatomical success rate is although 88 to 84%, but functional success rate can be as low as 5.6%, and plus there's always a chance that there could be recurrence in 12% cases. This is the paper we published to compare topical and intrastromal voriconazole, and we found that both of them work equally well when you add intrastromal voriconazole as well. And this is the protocol that we follow, and this protocol works well where we have intrastromal injections in our armamentarium. And I don't have to really prove my point. There are so many case series, so many studies which say that intrastromal voriconazole works well. And if you combine all of them, almost 85.7% of the ulcers healed in these case scenarios. Now, there are so many papers and papers after papers highlighting the same, and so many cases that I can show you which have responded to intrastromal injections without actually having to do therapeutic PKP. And even vascularization is not going to increase if you do that. And the technique is quite simple, and again, these are just cases which just prove my point without having to actually say anything. How the ulcers they heal. Now, this was post-LASIK fusarium keratitis, intrastromal voriconazole was given, and again it has healed without actually having to do a therapeutic PKP. And now, what evidence would you want more to say what you would do in these cases? And look at therapeutic PKP. It is fraught with complications, loose sutures, suture-related infections, persistent epithelial defects, endophthalmitis, graft rejections, hemorrhage, and the most ominous complication. I mean, you have an open globe there, and what do you do? That there is expulsive hemorrhage that occurs. Now, all these complications cannot and will not occur with intrastromal injections. And of course, you don't want to land up in a complication such as this. I'm sure none of us in the house wants to do that. And even if there is a recurrence, and look at the recurrence rate with therapeutic PK, you can have recurrence with this as well. And there are so many cases, as you can even have endophthalmitis with therapeutic penetrating keratoplasty. And even if there's a recurrence after TPK, your intrastromal injections are coming to rescue. So what more do you want after that? So to conclude, intrastromal voriconazole is the way to go in cases where the infection is recalcitrant and is not responding to medical therapy. Thank you for your attention.
Thank you, Dr. Namrata. Very relevant points. One question which I have is, earlier we used to use intrastromal amphotericin B, and then we have shifted to intrastromal voriconazole. So how do you rank both against each other?
No, not just now. Very recently, one of our students have finished a thesis on intrastromal voriconazole versus intrastromal amphotericin B versus intrastromal netamycin. And netamycin is the soluble one, so it is netasol. And we found that intrastromal netasol works the best, followed by intrastromal voriconazole, followed by intrastromal amphotericin B. Amphotericin B causes a lot of reaction.
Okay. Another quick question is, you have been using oral voriconazole also as of now, and you're probably working on it. How would you rank that against intrastromal voriconazole in such florid cases of fungal keratitis, wherein we think in some time they would be needing therapeutic PK? So in those cases, how do you work on intrastromal voriconazole and oral voriconazole?
See, if I showed you that slide which completely showed the algorithm which we have been following, and we've done almost now 350 plus cases following that algorithm, where we are the algorithm is very simple. If the ulcer is more than 6 millimeters in size, more than 2/3 in depth, we would go in for systemic drugs along with the topical netamycin that we would include. And the idea of doing that is that when the ulcer is large, another study I think which we published also in cornea just 3 months ago showed that systemic voriconazole, the tear levels as well as the plasma levels are much higher when we compared it with ketoconazole. Of course, in that group, we didn't have a group where we gave no systemic drug. So that was the thing. But it does help because we can extrapolate that because the tear concentration of the voriconazole is higher as compared to ketoconazole. So that really helps in healing of the fungal keratitis. And intrastromal, again, we are now modifying it a little bit because the paper that we published had mild to moderate cases. So we used intrastromal voriconazole for more lesions which are moderate, not severe ones. And probably that is why when we compared it with topical voriconazole, we found the results to be similar, not any better. But I think that because the lesions are not any deeper, so intrastromal will not give good results there. But if you do it in more severe cases, which we are doing now, intrastromal it does give better results. And I think even Arvind is going to do a randomized control trial now of intrastromal drugs vis-a-vis no intrastromal antifungal agents.
Thank you, Dr. Namrata. We would move on with